Antimicrobial prescription is an art. So you have to rationalize, you have to think, use your brains and optimize your antibiotic prescription. So I'm going to give you a brief outline on that. So these are the 5 things that you should know when you are doing a prescription of an antibiotic. First things, be mindful about antimicrobial resistance in your clinical practice. Number 2, treat antibiotic as a special medication. And there are certain skills that you must master to prescribe an antibiotic. Early source control and finalize the antibiotic duration. So I'm going to go through one by one in this lecture. So we have all heard about an AMR. Antimicrobial resistance is not a new thing. We know it's rampant in the hospitals. But are we thinking about AMR when we prescribe an antibiotic? Are we thinking enough? Is a question that we have to ask. When we are prescribing antibiotic, we are always having this problem of resistance. Imagine when you're prescribing metformin or enalapril or any other drug, you don't have to worry about resistance, isn't it? But when you are prescribing an antibiotic, we have a barrier which is called the antimicrobial resistance. The more that you prescribe antibiotic, the more that it will lead to resistance. So in 2050, the AMR is going to be rampant in the world, and it's going to surpass like 10 million deaths in 2050. And it's going to surpass the number of cancer deaths in the current context. And if you see these big pyramids, you can see that Asia and Africa is going to represent 88% deaths, nearly 10 million deaths out of the 10 million in the world in 2050. So aren't we going to face this problem in the future? But although antibiotic discovery is happening, it has been very slow and disappointing. You can see there's a void of new classes of antibiotics, and there are limited options available, such as these ones, but they are extremely expensive. For a country of having this economic nature as ours at the moment, we are unable to afford this kind of very expensive medication. So we have to fight AMR. There is no option for us. We have to fight AMR, and we have to do it together. Although individual efforts matter, the most efficient way is to work together and fight AMR by optimizing our antimicrobial resistance. The problem with AMR is it spreads from one person to the other, like chickenpox or any other infectious disease that we worry about, but we are not worried about AMR, isn't it? When we see a patient with ESBL or MRSA, are we worried that that person will spread it to us or another patient? We have to think about that. So when the hospitals are dealing with a lot of AMR, it will spill to the community. It will be in our waters, it will be in our contact services, and we will be, as healthcare professionals, we will be taking it to our homes as well. So what can we do? First, start with being mindful about AMR in your clinical practice. So how can we gauge AMR in the clinical practice? Think about these factors. How many percentage of people are on meropenem in the ward? Number of cases of hospital-acquired infections. Number of patients with C. diff-associated diarrhea. And how much of antimicrobial resistant cultures that you see, and how many people die despite giving broad-spectrum antibiotics. So don't we see this on day-to-day basis? So this is a clear evidence that AMR exists in our setting. Then treat antibiotics as a special medication, because each antibiotic prescription has a community impact. Not like metformin having an individual impact on a person, but if you prescribe an antibiotic per person, if it causes AMR, there's a community impact, not only the individual impact. So how to treat it as a unique entity? Now, initially we used to write antibiotic in red, but now we have a separate antibiotic chart, H1338, which is thanks to the College of Microbiology, which they have introduced. And this antibiotic chart serves as the cornerstone of antibiotic stewardship. So antibiotic prescription optimization starts from this. So ladies and gentlemen, everyone, try to use this chart in your wards and give up special treatment for antibiotics. So this is the chart. There are many sections in this chart. There are, the personal details. It has documentation of the allergy. You have to write the indication for the antimicrobial and whether the cultures has sent. And there are different columns that doctors should fill to antibiotic review. which is very important. Not only you prescribe an antibiotic, you have to review the antibiotic to see whether it is appropriate or not. Number 3, learn the skills. As I said, it's an art, so learn the skill of making a prescription of antibiotic. First, send a blood culture off first. In significant severe infections or septic or critical in patients, always send a blood culture before starting antibiotics. Then remember this phrase, start smart and focus. Starting smart means you start the empirical choice which will cover the most likely organisms which is causing that infection. So you have to do it after taking the microbiological samples, so you can later go into the next stage, which is focus. So when you have the microbiological sets in your hand, you can you can step down to a narrow spectrum antibiotic, which is focused and equally effective to the general antibiotic that you have given. So to elaborate further, start smart means there is a guideline introduced by the College of Microbiology. So refer to the guideline and do a guideline-directed therapy to a conventional infection, and then think whether this patient is escalation or not. The escalation indication depends on the severity of infection, right? So escalation to broad spectrum, you can do if the patient is critically ill or immunocompromised. And if the patient is septic or critically ill, do not hesitate. You can rationalize your antibiotic by escalating after taking your blood cultures. But then go to your next stage, focus. When you have the chance, you have to de-escalate the antibiotic. That is the next stage. We are good at escalating, but sometimes we are not very good at de-escalating antibiotic. So we are going for an equally effective narrow spectrum antibiotic. And if there is a culture report, it is very straightforward. Anyone can do the de-escalation. So there are two segments of that. Either you de-escalate from a broad spectrum to a narrow spectrum, or you do a IV to oral switch. We call it IVOST. So important thing is proactively think about de-escalation. Antibiotic review should be done by 2 to 3 days in the antibiotic chart, and the doctors should sign it. And de-escalation should be looked at case by case basis. And if you have a culture reports, that's wonderful. It's very straightforward. Any doctor can de-escalate the antibiotics to an equally effective narrow spectrum antibiotic. What is IV to oral switch therapy? It is said that when we are de-escalating from IV to oral, one thing is we are encouraging discharge of the patient. There will be lesser hospital stay, and also we are reducing the chances of antimicrobial resistance as well. So this is a big plus point. So how to do the IVOST? So these are the 4 criteria that you must look at if you are doing an IVOST. So number 1, as soon as the clinical improvement occurs, temperature settles for 24 to 48 hours, achieving stability of the parameters. Number 2, downtrending WBC and CRP. Mind you, you don't have to wait until CRP becomes completely normal. Downtrending CRP and WBC. There is no concern of GI absorption. The patient is eating and drinking, and there is no evidence of complicated or complex infections such as endocarditis, empyema. So in those instances, we cannot do the IVOST. Next step, early source control. This is a very important step. We have to again proactively think about it. So early source control, always think about this. Actively search for a source of infection and attend to it early, right? If there's cellulitis, you can treat the interdigital fungal infections. If there's an obstructed system, you can do necessary decompression. And if there's a collection, you can drain that pus. By doing this, you are necessarily reducing the severity of infection, you are reducing the duration of antibiotic, and early discharge, and a very cost-effective way of saving a lot of money as well. Then, what you do is finalizing the antibiotic duration. This is very important in our setting. Sometimes we don't take the decision properly, and we don't document it properly as well. So, what is the general principle behind it? So usually in a conventional infection that we see in a ward, cellulitis, pneumonia, UTI, these infections, usually IV to IV plus oral 7 days of antibiotics is usually enough. Or else think about if the patient is on IV antibiotics, if it is going more than 7 days, I think there should be something really wrong with the patient. There's either there's an uncontrolled source or there is a complex infection, right? Endocarditis. Or empyema, we have not controlled the source, so that's the reason it's going beyond IV more than 7 days. So try to get this point into your hand. If the patient is on at 7 days, you do a review, you do proactively do antibiotic review, sign in the chart, right? And see whether you can de-escalate from broader to narrow or do a IV to oral switch. So this is the important time point that we can attend to. So because the problem is there is more and more evidence that short courses antibiotics are equally effective as the longer courses. Even in neutropenic sepsis, now there is more and more evidence coming up. This is a really bad infections in neutropenic sepsis, but 5 to 7 days antibiotics are equally effective than 10 to 14 days of antibiotics. So there is more and more evidence coming up for antibiotic stewardship. Because I think we had an initial concern long time back that when you give shorter courses, if the patient stop antibiotics, that will lead to more resistance. So this is the other way around now that we have understood. The longer that you give, the broader the spectrum that you give, you are creating more and more and more resistance. So that we have to understand whether we can shorten our antibiotic courses, right? So if you give longer, if you give broader, there's a selection of resistance strains, and next infection you can get in a severe infection, and it will totally disrupt the gut microbiome as well, and it will induce more and more Clostridium difficile infection. Right. Thank you so much.